Emphysema. Definition. Emphysema, most severe form of COPD, characterized by recurrent inflammation that damages and eventually destroys alveolar walls to create large blebs or bullae, air spaces, and collapsed bronchioles on expiration, air trapping. Emphysema can be defined as having a loss of lung elasticity, permanent enlargement of the air spaces distal to the terminal bronchioles, and destruction of the alveolar walls. It can be classified under the umbrella term chronic obstructive pulmonary disorder, COPD. Types. There are 3 types of emphysema. Centriacina emphysema affects the alveoli and airways in the central acinus, destroying the alveoli in the walls of the respiratory bronchioles and alveolar ducts. Panacina emphysema affects the whole acinus. Paraseptal emphysema is believed to be the basic lesion of pulmonary bullous disease. Irregular emphysema. Acinus, the ending of a tiny airway in the lung, where the alveoli, air sacs, are located. In anatomy, an acinus is a round cluster of cells, usually epithelial cells, that looks somewhat like a knobby berry. Acinus, the ending of a tiny airway in the lung, where the alveoli, air sacs, are located. In anatomy, an acinus is a round cluster of cells, usually epithelial cells, that looks somewhat like a knobby berry. Stages of emphysema. Emphysema staging helps determine how much lung damage is present and how severe it is. The Global Initiative for Chronic Obstructive Lung Disease, GOLD, uses FEV1 measurements to help with this determination. FEV1 staging for emphysema. Stage. FEV1. I is equal to mild. Greater than or equal to 80% predicted. 2 is equal to moderate. Less than 80%, greater than 50% predicted. 3 is equal to severe. Less than 50%, greater than 30% predicted. 4 is equal to very severe. Less than 30% predicted, or less than 50% in chronic respiratory failure. Risk factors. The major factors that increase the risk for developing emphysema are: smoking. Smoking is one of the major risk factors for developing emphysema. The risk increases as the number of years the person has been smoking increases. Exposure to second-hand smoke. The risk factors or emphysema increase for people exposed to second-hand smoke according to the number of years exposed to second-hand smoke. Exposure to fumes or dust in the environment. People that work in close association with chemical fumes or dusts generated in mining, chemical plants or other industries are higher risks for developing emphysema. Pollution. Air pollution caused by fumes from vehicles, electrical generating plants that use coal and other fumes produce increases the risk of emphysema. In the underdeveloped parts of the world, indoor air pollution primarily from open wood flames used for cooking is the primary mechanism for acquiring emphysema. Etiology. Idiopathic. Smoking. Air pollution. Environmental factors such as occupational exposures. Lungs disease is equal to TB, pneumonia. Alpha-1 antitrypsin deficiency means lack a protein in blood called alpha-1 antitrypsin. This protein helps protect lungs from damage. Pathophysiology. Recurrent infection and irritants. Excessive mucus production. Loss of elastic recall of the airway. Enlargement of air spaces distal to the terminal bronchioles. Destruction of the wall of alveoli. Hyperinflation, overdistension, of the alveoli. Narrowing of small alveoli, reduced surface area for gas exchange. Breathlessness. Signs and symptoms. Frequent coughing or wheezing. A cough that produces a lot mucus. Shortness of breath, especially with physical activity. A whistling or squeaky sound when client breathe. Tightness in chest. Cyanosis. Chest pain. Hypoxemia. Anorexia. Lack of appetite. Diagnostic evaluation. History taking. As is the case with most illnesses, the healthcare professional will take a careful history to learn about the lung and breathing symptoms. How long has the shortness of breath been present? What makes it better? What makes it worse? Has there been an infection recently? Have the symptoms been getting more severe? Does the patient smoke? Does the patient have exposure to second-hand smoke or other toxic fumes? Are there other exposures of diseases that may be contributing to the shortness of breath? Is there a family history of lung disease? Physical examination. Physical examination will concentrate on the lung findings, but may also include the heart and the circulatory system. Is there an increased respiratory rate? Is the patient short of breath just sitting in the examination room? In addition to the ribs and the diaphragm, is the patient using the intercostal muscles, those between the ribs and neck muscles to breathe? When used, accessory muscles cause the appearance of indrawing, where there is observable sucking in of muscles during the breathing cycle. This is normally seen in people who have just exerted themselves as the body recovers from exercise or work. In patients with emphysema, it may be observed at rest. Does the chest appear enlarged or barrel-shaped? Does the chest cavity sound hollower than it should? Does exhalation take longer than it should? Since the elasticity of the lung has been lost, it takes longer for air to be forced out in the breathing cycle. Is the movement of the diaphragm decreased? Is the patient cyanotic, having a blue tinge to the skin color signifying lack of oxygen in the blood? When listening to the lungs, are there wheezes present, especially if the patient is asked to exhale quickly? Is clubbing present? This is a characteristic change in the fingernails and tips of the fingers associated with lung disease and chronic hypoxia. Exams and tests. Oximetry. Oximetry is a non-invasive test, in which a sensor is taped or clipped onto a finger or earlobe to measure the percentage of red blood cells that have oxygen. This value is usually greater than 92%. Results less than 90% may signal the need for supplemental oxygen for home use. Blood tests. A complete blood cell count, CBC, may be performed to check for an increase in the number of red blood cells. In response to lower blood oxygen concentrations, the body manufactures more red blood cells to try to deliver as much oxygen as possible to cells. Alpha-1 antitrypsin levels may be measured to look for the genetic form of emphysema. An arterial blood gas test will measure the amount of oxygen and carbon dioxide in the blood, and combined with other measurements can help the healthcare provider decide whether the body has been able to adapt to the lower oxygen concentrations in the body. In some laboratories, the arterial blood gas result will include a carbon monoxide percentage, most often found in the body because of smoking. For each hemoglobin molecule that has carbon monoxide attached, there is one less available that can carry oxygen. Sputum examination can help determine the presence of causative agent of lung problems. Radiology. A plain chest X-ray may show lungs that have become too inflated and have lost normal lung markings, consistent with destruction of alveoli and lung tissue. A CT scan can reveal more detail regarding the amount of lung destruction, but is not a normal part of the evaluation of patients with emphysema. Pulmonary function tests. Pulmonary function tests or spirometry can measure the airflow into and out of the lungs and be used to predict the severity of emphysema. By blowing into a machine, the amount of air that is moved and how quickly it moves can be calculated and provides information about lung damage. Results are compared to a normal person of the same age, sex, and size. Management. There is currently no cure for COPD. However, COPD is both a preventable and treatable disease. The major current directions of COPD management are: to assess and monitor the disease, reduce the risk factors, manage stable emphysema, prevent and treat acute exacerbation. Medical management. Bronchodilators. Bronchodilators are medicines that relax smooth muscle around the airways, increasing the caliber of the airways and improving airflow. Beta-2 agonists. Beta-2 agonists stimulate beta-2 receptors on airway smooth muscles, causing them to relax. There are several beta-2 agonists available. Albuterol, common brand name, Ventolin, and terbutaline are widely used short-acting beta-2 agonists and provide rapid relief of emphysema symptoms. Long-acting beta-2 agonists, LABAs, such as salmeterol and formoterol are used as maintenance therapy and lead to improved airflow, exercise capacity, and quality of life. Anticholinergics. Anticholinergic drugs. Regular use is associated with improvements in airflow. Corticosteroids. Corticosteroids act to reduce the inflammation in the airways, reducing lung damage and airway narrowing caused by inflammation. Some of the more common corticosteroids in use are prednisone, fluticasone, budesonide, mometasone, and beclomethasone. Corticosteroids are used in tablet or inhaled form to treat and prevent acute exacerbations. Other medication: expectorant bromoxine, potassium iodide, sodium citrate, mucolytic ambroxol acetylcysteine clearance of mucus, mast cell stabilizer sodium chromoglycate, ketotifen. Supplemental oxygen. Supplemental oxygen can be given to people with emphysema who have low oxygen levels in the body. Oxygen is provided through tubing via a nasal cannula or oxygen mask. Long-term oxygen therapy for at least 16 hours a day can improve the quality of life and survival. Nutritional management. Who are underweight can improve their breathing muscle strength by increasing their calorie intake. When combined with regular exercise or a pulmonary rehabilitation program, this can lead to improvements in COPD symptoms. High-protein diet for the regeneration of tissue due to recurrent infection. Vitamins supplement to prevent infection. Frequent diet with adequate fluid. Surgical management. A bullectomy is the surgical removal of a bulla, a large air-filled space that can squash the surrounding, more normal lung. Lung volume reduction surgery is similar. Parts of the lung that are particularly damaged by emphysema are removed, allowing the remaining, relatively good lung to expand and work better. Lung transplantation is sometimes performed for severe COPD, particularly in younger individuals. Nursing management. Ineffective airway clearance. Impaired gas exchange. Ineffective breathing pattern. Imbalanced nutrition, less than body requirements. Risk for infection. Deficient knowledge. Activity intolerance. Complication. Collapsed lung, pneumothorax. A collapsed lung can be life-threatening in people who have severe emphysema, because the function of their lungs is already so compromised. This is uncommon but serious when it occurs. Heart problems. Emphysema can increase the pressure in the arteries that connect the heart and lungs. This can cause a condition called cor pulmonale, in which a section of the heart expands and weakens. Large holes in the lungs, bullae. Some people with emphysema develop empty spaces in the lungs called bullae. They can be as large as half the lung. In addition to reducing the amount of space available for the lung to expand, giant bullae can increase your risk of pneumothorax.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.